Good evening, everyone. I'm Dr. Koyel, and I will be the moderator of this event. I'm working as an MSL in HaystackAnalytics, and I welcome you to today's webinar, which is infection using NGS. So, first of all, let me introduce you to the company Haystack Analytics. Haystack Analytics is actually a health tech company that is born at IIT Bombay. We are at a mission to bring genomics to the forefront of everyday healthcare. So we our first baby product, or which is a national award-winning product of developing the TB genomics. From there, we have started, and now way gone through a journey, and it is now have entered into the infectious disease, where we are trying to solve real healthcare challenges by providing clinically actionable reports and changing the healthcare meeting want to solve the healthcare challenges with innovations. So now I want to introduce you to our speaker, which is Dr. Mukul Pandey. Dr. Mukul Pandey, it's my pleasure to introduce Dr. Mukul Pandey, who is a senior consultant in charge of the pediatric intensive care at St. Stephen's Hospital, New Delhi. Dr. Pandey brings over a decade of experience in pediatric critical care nutrition and ECMO management. She's actively involved in teaching, training, and conducting workshops in pediatric critical care and infectious diagnostics. Her qualifications includes MBBS, DCH, DNB Pediatrics, FNB, Pediatric Critical Care, fellowships in ECMO, and a postgraduate diploma in pediatric nutrition from Boston University. An accomplished clinician and educator, Dr. Pandey has received multiple awards, including recognition at Criticare and Pedicon, and also continues to lead advancements in pediatric intensive care and infection diagnostics. So we are truly honored to have Dr. Mukul Pandey today with us as our chief guest speaker, and she will share her insights and expertise in the field of pediatric critical care and her experience using our infectious NGS product. Over to you, Dr. Mukul Pandey.
Good evening, everyone, and thank you, Dr. Introduction. And now I shall be starting with the role of this newer modality in the infectious disease scenario and how it is helping a clinician, especially an intensivist, and how it is helpful in a pediatric ICU. So I'll start with the burden of the infections. Every clinician and especially every intensivist who is involved in taking care of the child who is critically ill, so burden is really dangerous, and the numbers are really, quite fearsome. With almost 49 million infections occurring annually globally, this is a global data, out of which of almost 50 million, 11 million, almost 10 million of them die annually because of the infections. And out of those deaths, almost 50% of the death, that is 5 million death, occurs because of the resistance of the drug, because of the bad bugs, which are, they are horrible bugs, which are now becoming resistance each day. And of all these deaths, 30% of all death occurs in the ICU. So this is the burden which I, as an intensivist, face during my treatment in patients in the ICU, and the global data also supports that. Next slide. So pediatric sepsis, as per the data published in January 2024 in the International Consensus Criteria for Pediatric Sepsis and Septic Shock, we see that almost 25 million children are experiencing sepsis worldwide, causing more than 40% sepsis are identified within under the 5 years of children. And with the global fatality rate ranging from about 5 to 15%. And of this substitute, the newborn sepsis accounts for nearly around 1 to 20 per thousand birth. So every 1,000 births, almost 1 to 20 of the newborns are diagnosed with newborn sepsis, and out of them, they are almost 50 to 50%. They require some form of the treatment in the NICU. So this is the global data, which is really, worrisome. Okay, so next is the real challenge. So as an intensivist and as a clinician, what challenge we face, because the data is so horrible, and we are daily facing the new bugs, and even the older bugs are now resistant to the common antibiotics. And with we in the last 10 years, from 2000 to 2010, we see no global or any new antibiotics which has come up especially in the pediatric age group. So lack of newer antibiotics, and adding new antibiotics, I feel personally, is not a solution, because if we are not going to control or have a good control over the antibiotics, we are daily going to face these bugs, which are getting stronger and stronger day by day. And no matter how much guidelines we make, if we don't follow the antibiotic stewardship, we are going to face these horrible data in coming years as well. What is the current diagnostics, and what actually we only find what we are looking for? So currently our practice mostly is that we make a syndromic diagnosis. Suppose, for example, if a child comes with acute febrile encephalopathy, so we make a syndromic diagnosis, and we think something, based on our history and examination, we think that yes, this can be the further differentials, and then we order the test based on those differentials. So what we think prior, we find the test for it, and then we order the test for it. But actually sometimes the scenario is the other way around. Whatever we are not thinking, even those bugs could be the possible culprits in the patient. And where we only look at the community level, we do the rapid test, and then we are dependent on the serological assays for few diseases, then microbiological assays for few microbacterium and everything. Then we come up with the newer microarray and the PCR based technologies, where they are quick, and the certain panels of bacteria or infections or fungus, if we think in those panels, like if we think this could be the possible etiology, and my panel covers that etiology, then only I'll be able to get those reports positive for those, which will be helpful by the molecular assays. But now with the help of the newer tests like NGS, where we are sequencing the genome of any possible bacteriological or viral agent that is present in the different serology or blood, or maybe different specimen of the patient. So with the help of that NGS, there are new technologies with the help of the NGS, where we can diagnose the genome of that microorganism. So in this way, it is helpful, and it is quite a lot helpful in the patients, especially in the ICU setup, where time matters a lot. So with the help of this technology, we are now shifting our paradigm from hypothesis intense diagnosis or the syndromic based diagnosis to the hypothesis free based diagnosis, or the precision medicine diagnosis, where each child or each patient will have a precise diagnosis, and based on that precision based diagnosis, we will be able to give the tailor made therapy to that, or specific precision therapy to that particular patient. In the commercially available panel, as I have already discussed, the common organisms panel is being made based on the microarray technology, and those, if that is present in the patient's blood or in any specimen, then only that organism we'll be able to detect. So this is the problem, where in newer and newer, every day the new and new bugs we are discovering, and we are describing the new bugs. But the conventional panels or commercially available panels have very commonly used or commonly described organisms, be it gram-negative bacteria or maybe gram-positive, and few of the viruses. So I will go through, as a clinician or as an intensivist, I will go through further my journey with the NGS based on the cases. So I will discuss few cases in the subsequent slides, and which will tell my journey with the NGS, how NGS has helped me, with every cases, how it has helped me to gain confidence in in making a diagnosis of the patient, and as well as in making the treatment changes, and how it has helped the patient. So first case is A common case of 3-year-old well-thriving, immunized and developmentally normal child who presented with fever, cough, cold for 7 days with fast breathing of 5 days, and he was admitted outside as a case of pneumonia and was referred because of the worsening. The past history was not significant. He was, as usual, started on a high flow support in view of respiratory distress. The lung ultrasound was done, which showed pleural effusion and some doubtful lesion in the liver, which was later confirmed to be a large liver abscess. The pleural tap we did was showing this kind of hemorrhagic or purulent, seropurulent discharge. So because of this, two pigtail catheters were inserted and intrapleural fibrinolytics were administered. And as usual, we started with the broad spectrum antibiotics, thinking that all the gram positive and gram negative, along with the anaerobes, we covered everything based on the clinical picture. The routine blood culture and pleural cultures came out to be sterile. So just a second. But after 5 days, I think this one slide is missing. What happened that in the next 5 days, child started deteriorating. So what happened after 5 days when child started deteriorating on these broad spectrum antibiotics, then this was my first experience with the NGS. Then I thought on day 5 that to send the sample, because we still did not have the etiology of the pus, and the child was not improving on the broader spectrum, these syndromic based diagnosis. So NGS was sent, and in the meanwhile, NGS showed within 24 hours, we got the report, and it was suggestive of nocardia. And no resistant gene, ARGs were negative, so it was not detected. So we started, because of the diagnosis of nocardia, we changed our antibiotics from ceftriaxone, tico, and metronidazole to, we changed it to Septran, because Septran is mostly the drug of choice for disseminated nocardiosis. And we started, and the child started showing improvement on the Septran therapy. And then the pigtail was out, respiratory support was out, and he was discharged. And then we looked up in the literature, and we found that yes, nocardia can be possibly found in disseminated nocardiosis, can be even found in non-immuno or immunocompetent patient as well. And the therapy is like very prolonged therapy, up to 6 months, up to 1 year. So he's doing well on Septran therapy, and follow-up, we continued Septran therapy even after discharge for next 6 months, and he's doing well with no further lesions or no further abscess. The immune deficiency profile was done simultaneously, which was normal. So he was a normal immunocompetent child having this nocardiosis, which is very well reported even in an immunocompetent child. And without the help of NGS, we could have nowhere treated this child with Septran, and we could have, the child could have worsened, and we may have lost the child also, because it's a bad disease. It is known to cause deep-seated abscesses and very difficult to control. Moving on with the second case. Now, this is a 6-month-old child who presented with fever for 5 days, loose motion, abdominal distension for 3 days, and fast breathing for 1 day. He was a 30-weeker inborn, 1.4 kgs, with a history of NICU stay for 1.5 months. He was bottle fed, but he remained well after NICU discharge. So he was also started on some respiratory support, and the initial lab showed leukopenia with 2600 of TLC, with neutropenia of absolute neutrophil counts of 500 only, and thrombocytopenia. His inflammatory markers like CRP and procalcitonins were very high, and the renal and other functions were within normal limit. So this time we send the respiratory NGS quite fast, that is on day 1 or day 2 of admission, and it showed Pseudomonas and Streptococcus pneumoniae. Again, considering that Streptococcus pneumoniae is very commonly found in this age group of child, we considered the strep sepsis, and you started on ceftriaxone. But again, child worsened clinically in next 48 hours with further fall in leukopenia and thrombocytopenia. And meanwhile, to our savior, the culture this time grew at 48 hours Pseudomonas aeruginosa, and it did not grow Streptococcus. So, and again, it was sensitive. It was not sensitive to the cephalosporin, and it was the resistant type of Pseudomonas. So we increased the antibiotic or upgraded to meropenem, and CSF examination was done, which was normal, and child improved on escalating the antibiotics. So in this, we retrospectively thought that we could have added or upgraded the antibiotics, because NGS was showing both Pseudomonas as well as Streptococcus. But at that time, we were also not very confident, and I was also on a learning curve of this, this journey. So I thought that why not to cover the Streptococcus, which is very commonly seen. But he was a NICU graduate child, so he had a very fair amount of chances of having the pseudomonas kind of, or these kind of bad bugs harboring in the body of that child. And further immunodeficiency workup also showed that he has a decreased natural killer cell activity, and the child is doing well in follow-up and advised for exome sequencing for confirmatory diagnosis and for the decreased NK cell activity. So in this way, we managed the child with the help of NGS. We could have now, my confidence grew further better with the second case. Then moving ahead with the third case, he was a 10-month-old previously well child, presented with complaints of high fever and multiple episodes of seizure. The clinical examination showed the sign of meningitis. He was started again on broad spectrum antibiotics to begin with the third generation cephalosporins and vancomycin. Initial lab shows leukocytosis, very high CRP, and the CSF examination done on day 1 was showed, again showing 80 cells with 90% neutrophils, protein of slightly high protein and low sugar, suggestive of all meningitis. Now the problem is, what is the bug? Now we did the CSF and we sent the CSF NGS, and it was shown to be found in Acinetobacter, which was resistant to the APH3, that is the aminoglycoside resistant gene was detected. Rest of the genes was not detected. Okay, so we changed the antibiotic. We did, because the beta lactamase resistant gene was not found in this Acinetobacter. So we continued with the ceftriaxone, and vancomycin was stopped because the bug was Acinetobacter, and safely I could stop vancomycin. We continued with the 14 to, I think he was a newborn. No, so we continued with the 14 days, 2 weeks treatment of ceftriaxone, and he improved and went home. So in this way, this helped us a lot. Otherwise, without this report, we could have given that 14 days treatment of both ceftriaxone and vancomycin. So unnecessarily 14 days vancomycin was avoided with the help of this test. The next case is the, can you please change the slide? I'm unable to change it. Mayank, can you change the slide, please? Yes. So next case is a 9-year-old girl with complaints of 5 days fever, cough cold for 3 days, and seizure and features of raised ICP for 1 day. So all the examination finding was suggestive of raised ICP, very poor GCS 6/15, unequal pupil. So he was managed immediately with all the neuroprotective measures like intubation, anti-seizure medications, and all those things, and a broad spectrum ceftriaxone, vancomycin, and he is, along with that, antiviral acyclovir was also started in this case. Next, please. His MRI brain showed very extensive multifocal infarcts in the extensive areas of, occipital lobe, parietal lobe, the most mid part of the midbrain, and the angio was normal. So huge infarct was present in the major areas, the right hemispheres. We did a CSF. Next slide, please. We did a CSF examination in this, and it was no cells was found with slightly high protein and normal sugar. But still we sent this CSF NGS, because by that time we have been gaining more confidence and we wanted to know what the etiology was. And to our surprise, the CSF NGS grew Streptococcus pneumoniae with no resistant gene was detected. So we completed with the 14 days antibiotic of ceftriaxone, and we stopped vancomycin and the acyclovir. But child has extensive brain damage, long-term prognosis was explained, and she was sent home on tracheostomy with aggressive neurorehabilitation care. We then looked of the final diagnosis in all the 4 cases. In case 1, it was a nocardiosis or disseminated nocardiosis with ruptured liver abscess. In case 2, it was a pseudomonas sepsis. In case 3, it was an Acinetobacter pyogenic meningitis. And in case 4, it was a stroke, extensive hemorrhagic stroke secondary to the Streptococcus infection. So what we learned from each case is that in case was one case, first case helped us, the NGS helped us to detect the atypical organism, which is known to cause in the literature deep-seated abscesses, even in immunocompetent kids. Case 2, the unusual organism from any blood or sterile site, we thought of immunodeficiency and we find the immunodeficiency in that child. Case 3, with the help of NGS, we are now seeing one so-called the nosocomial organisms found in hospitals only, in very well fair enough coming from the community, and sometimes they are resistant also. Luckily, in our case, it was not resistant, but nowadays, very commonly, we are seeing Acinetobacter and Klebsiella, which are Klebsiella E. coli, especially, which are ESBLs or extended spectrum beta lactamases, which are resistant to your first generation or first line antibiotics like cephalosporins. In case 4, it was streptococcus driven extensive stroke, where even the CSF cells are absent, but then with the help of NGS, we could find the etiology. And then in the literature, we found that Streptococcus pneumoniae meningitis, the incidence of stroke is almost 50%. And even without the CSF picture showing cells in these stroke cases with meningitis and with encephalitis, Streptococcus pneumoniae is known to cause these kind of notorious complications with the meningitis. Next slide, please. So with these cases, my take home message is we should, can you just go with the next slide. Yeah. So based on these cases, my take home message for these 4 cases, that we should definitely, should not rely on just the CRP and procalcitonin, because ultimately they all suggest inflammation. And I've seen many times in the viral infections also, the procalcitonin is quite high. And even in the bacterial infections, it could be other way around, where the CRP or procalcitonin might not be high. And so both ways they go haywire, may or may not, clinically correlate all the time. Be curious to know the etiologies, because it not only helps in escalating, but it also helps in de-escalating the antibiotics and de-escalating the management as well. Advanced diagnostic tests like NGS and other tests helps us to know more about the etiology and helps us in precision medicine. ESBLs are freely roaming in the community, so we should be very, very, particular before writing any antibiotics on OPD basis for normal cough and cold, because it is doing very, very harm rather than benefiting the patient. And last but not the least, NGS has revolutionized and opened the door in healthcare system towards the, we are moving ahead towards the precision medicine, and NGS helps us a lot in that. So with these tests, I shall be going further with what is NGS and what is how it helps our patients. So NGS we have been commonly used in from many years in the research methods, especially in the oncology, diagnosing the different genes and exomes of the various cancer genes and cancer cells. So in the infection, as an intensivist, it is I'm very fond of this test because the turnover time is quite low, and I am able to give the precision medicine in a very confidently. I can, change or de-change or maybe de-escalate the antibiotics very confidently. So what NGS do is just basically it sequences the sample is taken in a sequencer, and it sequences the whole exome of the any microbacteria or any microorganism for that matter, may it a virus or bacteria or fungus, or maybe mycobacteria or atypical organisms. So it detects the exome of that organism, and it gives us a report in a computer automated format. Next slide, please. So it is gaining ground in infectious disease, obviously globally. Various papers are being published every day nowadays in reputed journals like Journal of Microbiology and virology and everywhere, where it is founding its ground in the diagnostic as a diagnostic modalities in diagnosing the microorganisms. So this is again few papers where metagenomic next generation sequencing are helpful in, apart from pediatric oncology patients. Even in oncology patients, it is helpful in detecting the various bloodstream or other infections. Next slide, please. This is a global conscience which is published in 2021 spring issue of Microcosm, and which states that since the discovery and isolation of DNA, investigative processes aiming to decipher life complex and variable genetic codes have become indispensable in public health infrastructure. It is no more a matter of research now, and advances in nucleic acid sequencing have revolutionized the way we identify, characterize, and track these causative agents of disease. Where symptomatology was once considered the gold standard for diagnostic, now NGS or next generation sequencing has now become enabling the precision public health. It is no more being used in research work, Now it has come to the ground level, and it has come to the most very soon it will become the point of care test for every patient. So it is comprehensive, it is accurate with a very good turnaround time and around less than 24 hours. It is cost effective, sensitive, specific, precise, reproducible, and easy to perform, and impactful golden hour for clinical decision making. The leap where has taken place, which I have already discussed, that from intuitive medicine to the empirical medicine, where we make a syndromic diagnosis and we make an empirical decision, and we add cocktail of therapies of antibiotics and other therapies based empirically. Now we are moving ahead, and apart from the evidence-based medicine, now we are moving towards the precision medicine, where diseases cause specific microorganisms for each and every patient is being understood. The exact diagnosis is a routine now, and it should be it should be tried to find out in every patient, and we should not be just dependent upon the serological methods where they have a very, very false positivity and negativity both. And conditions are treatable with predictable effective rule based therapies. Now with this kind of background and the clinical picture, I will now like to move ahead with Dr. Koyel, who will introduce us and give us little more detail about this technology of NGS. Over to you, Dr. Koyel.
Thank you, Dr. Pandey. Um, so as you have heard about the technology and about how NGS is already making an impact in the diagnostic in the diagnostic world, and is already we can see so many cases has been solved fantastically with NGS. So with this, I would like to give you a brief about how we are working and what is our product. So our first product is infection NGS, which is a bigger panel. We have smaller panels in this also. So talking about infection NGS, first I would like to tell you the setup. Here you can see that this is a sequencing setup that we are using, where it is visible on the upper right corner that we utilizes an Oxford nanopore, which is developed a sequencer which is named as MinION, and this is connected to a CPU. In this case, it's a NUC box or a laptop which is used for which is loaded for a plug and play use. The lower bottom left image that zooms in the MinION sequencer, or the MinION Oxford nanopore sequencer. It's a handheld portable sequencer that fits for field use, so that it can be taken for different places also. If you want to track an outbreak or an epidemic, it can be carried to different places. And This is a electrical component, and which is for continued use. And you can see there's a device in it that is named as flongle. The flongle is essentially it's consumable, and for each batch of sequencing, this is changed. So what happens inside this flongle, that you can see in the lower right hand side corner, each strand of a double stranded DNA is pulled by an adapter protein through the nanopore, as you can see, which results in a negative charged base pair that causes an electrical disturbance that is already existing, or an existing flux across this nanopore. So each of this electrical disturbance is called a squiggle, and this squiggle is captured, converted, and is into a recordable signal, which is then translated into a base pair by a software, which is known, in our case, it is known as a MinNo software. So, in this way, the setup, the NGS works. So, what happens? This is a test where we call this as an antagonistics test, which means that it's a single test that can be used for all kind of sterile samples. We take all kind of samples from blood to swab, to aspirates, ET aspirates, bowel fluids, pericardial aspirates, tissues, pus, liver abscesses, any kind of abscesses, uh, uh, and we also take urine, but it's the bladder representation or suprapubic tap, or in and out catheter urine, CSF fluids. we uh, uh, we don't uh, we don't take sputum and stool yet, because there are high chances of getting commensals in that, and that can result in false positive results. So other than that, we take all kind of sterile body fluids. We take whole blood also. So how is the process from that how this is like how the process is carried on after the collection of the sample. So once the sample is collected, what happens once the sample is collected, it has to be collected in a very aseptical way, so that there is no contaminants that comes up. After the collection of the sample, it is taken in a 4 degree. It is stored in a 4 degree and also transported at 4 degree. The temperature is maintained by using so the transportation is done by using ice packs and everything, and then it is taken to the lab where the DNA is extracted, and there are some processes which is called as the pre-sequencing preparation. After this preparation, there are some 4 steps and library preparation. After the pre-sequencing preparation, the is done, the sample is loaded into the sequencer. Once it is loaded in the sequencer, from there the sequencing takes place around 6 hours, and then the data analysis is done by an automated software, and then the report is generated. So from the collection of the sample to the generation of the report, the whole process uh, uh, takes around a tat of 24 hours, which so we commit so we can commit a tat of 24 hours, where we can give the report to the uh, clinician or to the patient. Uh, so so this is a TRF. The TRF is required because it's a test request form. In this TRF, there are different categories that needs to be filled. Like it is important because it helps us to know the patient's name, the patient's details, if there are any kind of patient's history that can also be filled. Also, there are this is very important, so that there is no misidentification of the samples or everything or anything. So it is very important for the clinician to fill the TRF, and this is given and this should be given along with the sample, so that it is easy for us uh, like uh, to correlate or to see the TRF in case of a discordance or anything like that. After that, so what why infection, why we say infection NGS, why you should do the test. So this is what we are trying to do in infection NGS is that there are organisms that in cultures we don't find. There are many organisms that are present in the book, but they do not come up in the clinical test many a time when doing a culture or some other kind of panel test. So why so? Because there are some limitations that can be in culture, like there are organisms which are difficult to culture or unculturable organisms. There are organisms that are very rare or unknown organisms, or a very new organism may come up which whose culture methods are not yet known, or there may be some specific requirements that is not fulfilled or that is not present in the lab for culture, some very specific culture requirements or nutritional requirements, or there can be some certain certain fastidious growing or fast growing organisms which are difficult or to track or difficult in culturing. So these kind of limitations, when that comes in culture, those things, those type of organisms can now be detected and seen in a clinical report by doing this infection NGS. So in infection if we in infection NGS, if we do a infection test, we can also see organisms which are in a report which maybe sometimes are not frequently seen in a culture report. So that's why we say that infection can detect all kind of organisms which can be a limitation for a culture. So we are not saying that it can replace culture, but it can be a parallel to culture. Yes. And also, for fungal infections, also it becomes very challenging when it comes for a fungal infection, because they are more difficult to treat, and the treatment requires at a very early phase, because they can become very nasty infection when if it stays for a long time. And identifying or culturing a fungus is very difficult, because it takes a long incubation time. Then also it requires very special media to culture a fungus. There are certain also identification becomes sometimes becomes a challenge. This It can be misidentified. So these are some of the limitations that one can face on culturing on using culture for a fungus. And these limitations again can be overcome, as infection can detect fungus also, and it can detect and give you a report within 24 hours, so that the treatment can be done or started as early as possible. Uh, with this, I would say that this is like a overview of our infection test, where we can test. This is where we can test all kind of infections, majorly from neurological infections, orthopedic infections, gastrointestinal, bloodstream infections, even rare. Infections in very complicated places like ocular infections, etc. We can test soft skins, respiratory infections, etc. And for all infection, the result will be given, or the tag time is 24 hours. Uh, so the sample type, there are different type of samples that can be taken to do this test. So from we take OPNP swab, we take blood. If we take blood, it's the whole blood, and the minimum volume, you can see each sample types and the minimum volume required. And I would say that the minimum volumes that has been shown in here is already validated, and one should try to stick to the minimum volume, because anything less than that can lead to false negative results, as these are all the volumes for each sample has been validated. You can see here, and then so what I would say that it's in a culture-free test. The report of this test is given within 24 hours. We can detect co-infections, polymicrobial infections. We can because the test is based on NGS, and the samples that has to be collected should be collected aseptically, and the transportation and storage should be done accordingly. Like as I mentioned, uh, it should be in 4 degree. Then so this is a report summary. This is to show that how you can see a report. So you can see that there will be pathogens detected, a column where all the pathogens that are detected will be written, and a comment will be written to that. Like if it is an environmental or a opportunistic pathogen, it will be written. If it is an obligate pathogen, it will be written as a true pathogen or a obligate pathogen, and what kind of pathogen it is, like a gram negative bacilli or a gram positive cocky or something like that. So, and then you can see that on the right hand side, you will get a table where you will have all the antimicrobial resistant genes, and if they are detected in the status column, it will be written as detected. If it is not detected, it will be written as not detected. So this is a brief summary of how you will get the report. Then this is our own publication. If anyone is wants to know what kind of validations has been done, how many samples has been studied, what is the sensitivity, the positivity, how the sensitivity and the specificity, how the calculations has been done, all this has is mentioned in the paper. This is our own published paper, and it can be provided if anyone is interested to know. This is also another publication where a rapid culture-free detection of carbapenem-resistant Klebsiella pneumonia was done, and this is a case of bloodstream infection where genomics was used. So this publication is also from has been done by our members, and if anyone is interested, they can also go through and read this publication, this paper. With this, I would like to end the talk, and I would really like to thank Dr. Mukul Pandey for giving such an beautiful talk and a real insight about the cases that she has gone through, and how she has used and benefited from the infection NGS results. Thank you, Dr. Pandey, and thank you for joining. Thank you everyone for joining.